All right. Good morning, everyone. I'd like to thank Professor Sharif for inviting me to give this speech. And I believe it will be useful to you all because when I was a resident, Basilar Imagination always seemed to be so confusing because so many of my mentors, my professors use different lines, different angles, and different classification methods. So it always seems so bizarre and so difficult to diagnose. And when things become so difficult and so complex, we need to actually move to a more simplified version to actually understand it. So my presentation will be on how you should diagnose basilar imagination and a simplified classification of it. The surgical approaches and the surgical methods are different and will be a different topic to present. So in short, basilar imagination, as you all know, is the odontoid prolapsing into the already limited space of the foramen magnum. And my definition is oversimplified, and there are different methods to actually measure when this odontoid prolapse is called basilar imagination and when it's considered normal. It could be congenital, it could be due to an acquired anomaly, due to other reasons, due to other systemic disorders. And in the literature, you can find different names for it, which is another reason why it becomes so confusing from time to time. Some authors would like to call this basilar impression. Some authors would like to call this atlantoaxial impaction. And in some instances, it is wrongfully titled as platybasia. So it's not a new definition. Basilar imagination is actually a very old entity. And a German anatomist had a visit to Italy where he was gifted two different skulls from cretins, cretins meaning mentally retarded patients. And he studied these two skulls when he returned to Germany. And he found in 1790 that these skull bases had deformations, had softening, had some kind of flattening. But at that time, Ackerman believed these deformations were due to the mental retardation of the patients, and he defined these as different entities of cretism. And later on, Bogart, which we will use his name again in the definition methods, in 1865 described the condition and its causes, possible causes, and its possible consequences. In 1876, Virchow submitted more detailed descriptions of the condition. In 1880, Gravitz made more anatomical studies of six skulls with basilar impression, and he used the term basilar impression back then. In 1901, Hohmann actually performed the post-mortem findings, and he tried to correlate the neurological status of the patients while they were alive with these basilar impressions. So in 1911, Schuller published in his book the first clinical entity of basilar imagination, and he was the first to diagnose the patients before their death, and he used radiological evaluation. And afterwards, Chamberlain took this a bit further, which we will also mention his name later on, and he used radiological evaluation to correlate the odontoid with the neurological abnormalities. And in the same year, Temple Fay actually operated on two of Chamberlain's patients with suboccipital decompression, and he reported clinical improvement. So we're in 1939, and we actually have a very good idea of what basilar impression is at that point and what it can cause and how the patients could be treated. So the etiology is more, why is the etiology important? Because it helps us first to diagnose clearly what basilar imagination is and how we should classify it, which is more important when how we should treat it. Why is it so difficult to classify? One of the reasons is that the cervical spine has a lot of change from birth to adulthood. And this causes a lot of different pathologies at this craniovertebral junction. And basilar imagination, basilar impression is the most common form of craniovertebral junction malformation. And as I said, it could be acquired. It could be due to a CD1, C2 facet instability. It could be due to a congenital osseous defect in the skull base. It could be due to a degenerative process due to rheumatoid arthritis and other bone disorders, or it could be a developmental anomaly. I mean, the person could be born with the occipital floor lying lower than it should. They could be born with the odontoid prolapsing into the foramen magnum. The person could be born with a Chiari syndrome that could be seen with basilar invagination at the same point. So there are a lot of studies on the pathogenesis. There's a study even blaming viral infections for basilar invagination. There are some genetic studies that have been performed blaming basilar invagination. A lot of the studies are actually focused on the mechanical dysgenesis of the craniovertebral junction, as I said, the C1, C2, the instability of the facet syndromes, or it could be due to embryological dysgenesis. This was the mainstream idea of why we thought basilar invagination existed. And then Atul Goel, Professor Goel from India, he has probably the largest series of basilar imagination up to date, with numerous publications and numerous number of patients he has treated. So he came up in 2007 with an idea that these patients all had an atlantoaxial instability, which is something we see frequently in the lumbar region. And he oversimplified this as a spondylolisthesis. He said that the atlas, the C1, slipped over the axis, the C2, causing a spondylolisthesis. But this was due to some compensation method, that the patient had an overlying pathology and the body itself reacted to this, trying to compensate a malalignment. And this, in the end, caused an invagination of the odontoid. So in 2009, he tried to enlighten us on the pathophysiology of it. Goel published a paper where he divided these patients into group A, which is an acquired anomaly, and these patients, he stated, had an instability. Why is this instability important? Because it helps us choose which kind of treatment methods we should have. And he said that these patients had a C1, C2 listhesis, and it was a more acute pathology, and this instability needed to be treated. But in group B, he stated that these patients were stable. It was a more chronic process. The odontoid and the clevis were aligned. And in most of these patients, posterior decompression was usually enough. The history and physical are something that I'm not going to get into too much detail, because it changes according to the extra findings the patients had. It changes according to the degree of the odontoid prolapse. It changes according to if there's CSF obstruction in the intracranially, if there's CSF obstruction in the spinal canal, if there's a medullary dysfunction, if there's syringomelia. So there's a wide range of symptoms and findings we have in these patients. But when we try to focus on the main symptoms these patients usually have, most of them apply to the clinic with occipital or suboccipital headache, and it is aggravated by the Valsalva maneuver. So any kind of coughing, straining, laughing, and weightlifting would cause some sort of suboccipital headache, but it's not very specific. What we see in these patients is most of these patients have a short neck, and roughly half of these patients have torticollis. But previously, we thought that this was caused by the pathology. But now we understand that this may have been resulting in the pathology. So there's not a clear consensus on it. What does this mean? These patients may have been born with a short neck causing a basilar invagination. That's one theory. And the second theory is that these patients developed basilar invagination, and in order to avoid these symptoms, to compensate for the pressure of the odontoid into the foramen magnum, they developed a shorter neck to decrease this pressure. So when there's a lot of pressure on the spinal cord or the medulla oblongata, we know that we can have different findings: weaknesses, numbness, paresthesias, pyramidal symptoms, dysphagia, dysarthria, and cranial nerve findings. So the evaluation is one of the most important parts of basilar imagination. And this is sometimes where it gets confusing because so many different publications are out there with so many different lines and angles, and it just gets too confusing. So when we look at the literature, there's a mainstay of four main different entities that we should be familiar with when trying to diagnose basilar imagination. And this is very simple. We won't get too confusing, but we should know that these patients need a CT scan. A CT scan gives us a clear visualization of all the bony structures of the craniovertebral junction. Previously, a lot of X-rays were used, but X-rays are sometimes difficult to see the odontoid, to see a clear visualization of the hard palate. And an MRI in these patients, especially if we are certain of basilar imagination and if we are looking to follow up or treat the patient, it is important to show us if the patient has any other abnormality, if there's a problem with syringomyelia, if there's a Chiari malformation, etc. So on the left, you see a clear image of a sagittal reformatted CT of a healthy patient. So one of the main things you should be familiar with is the basion, which is the anterior part of the foramen magnum of the occipital bone. You should be familiar with the clevus. You should be familiar with the opistheon, which is the posterior part of the foramen magnum. And basion and opistheon are the main bony structures surrounding the foramen magnum. We all know the odontoid peg and the hard palate. The hard palate is important for us when we try to evaluate these patients. So my main lines would be the Chamberlain's line. I would get into the details of how we measure the Chamberlain's line. The second line, one of the most important lines, is the McGregor's line, which is extending from the hard palate to the most inferior part of the occipital bone. The McRae's line is a pretty simple line. It's the line extending from the basion to the opistheon. And the Weckenham line. The Weckenham line sometimes is referred as the clevus line, and it's a line extending from the posterior part of the clevus. And this angle will be very important for us. So the Chamberlain's line is, as I said, the posterior aspect of the hard palate, extending all the way to the posterior margin of the foramen magnum. So odontoid, the end of the tip of the odontoid should lie below the Chamberlain's line. Any kind of patient that has an odontoid extending over the Chamberlain's line would come pathological. And they have a very confusing definition for the Chamberlain's line too. And why is that? Some authors claim that even a 2 millimeter deviation above the Chamberlain's line is diagnostic, and some authors claim that 5 millimeters is more than enough. So why try to measure specific amounts and focus on the amount of the odontoid prolapsing? So instead, we can just use the Chamberlain's line as a reference. If the odontoid is lying above the Chamberlain's line, we won't stop there. We won't say, okay, this is a basilar imagination, but we will have a rough idea. When the odontoid is over the Chamberlain's line, we can see that this patient may have an anomaly. So then we use the other tools as well. The second tool we can use is the McGregor's line, which is also very specific. And this seems, at first, when I first read it too, it seemed funny. I mean, why use the Chamberlain's line and why use the McGregor's line? They both seem so similar. Yes, in a normally anatomically aligned patients, these are very similar. But some patients, you will see that they have a very different occipital bone, they have a very different skull base, they have a very different clevus, a very different alignment. And this will come in handy too. So the McGregor's line is the line extending from the posterior part of the hard palate to the lowest part of occipital bone. And again, or some authors have different measurement methods. They say that sometimes it should be, odontoid should be 4.5 millimeters above the McGregor's line, or it should be 7 millimeters above the McGregor's line. Again, you should not focus completely on these millimeters. These are all would be helping you defining basilar invagination. So we have the Chamberlain's line and we have the McGregor's line. The second line, one of the most important lines, the McRae's line, which is pretty simple to measure, extending from the bastion to the opistheon. And again, some authors say that the basilar tip of the odontoid should lie 5 millimeters below. Some say that it should be roughly similar to where the McRae's line is, and some authors claim that it should be above 7 millimeters. Again, I'm not recommending that you focus on the numbers. Just focus on these lines and be familiar with them. If there is an odontoid coming closer towards the McRae's line, or if it's extending above the McRae's line, again, it's indicative of basilar invagination. And the Weckenham line, the clevis line, is pretty simple. It's a line drawn from the posterior part of the clevis. And most of the time, we should see that the odontoid should always lie behind this Weckenham line, behind meaning more anteriorly placed. In this image, we try to see that the odontoid should maybe touch it or maybe extend over it very minimally. But even these lines sometimes don't help us in trying and diagnose these patients. So one of the last methods that I want you to focus on is this angle. So we have the Weckenham's line extending from posterior part of the clevis, and we have the McRae's line extending from the bastion to the opistheon. This angle is very important for us because this angle is usually more specific in diagnosing these patients, and it's called the Bogart's angle. Remember, I mentioned Bogart in the historical part of my presentation. And this angle should always be between 119 and between 119 and 135 degrees. This is something you can memorize. Unlike the other millimeters, this is a nice range, and this is usually very specific, and it doesn't get too confusing. So what you do is you have 4 different measurement lines and 1 very important angle, and this is usually indicative of basilar invagination. The reason why I want to simplify it, because I said when I was a resident, it got so confusing with so many different, and there is still newly published papers with a lot of different techniques, a lot of different lines, a lot of different angles. Yes, you can use these later on. If you get into basilar invagination, if you perform 10 to 20 basilar invaginations per year, and if you want to publish them, then you can use these different lines, like the palate and the internal occipital protuberance line, which is used a lot in publications. But simply stating and simply diagnosing and simply just following up on patients, the 4 lines and the 1 angle that I mentioned would be more than enough. This will just get more and more confusing otherwise. So this is a pathological patient. On the left, you see my previous patient, the Chamberlain's line extending from the hard palate to the opistheon, and the odontoid is not extending over the Chamberlain's line. But when we come over onto the right side, you can see that the odontoid has prolapsed 15 millimeters over the Chamberlain's line. This is very indicative of basilar invagination. When you see this image, there's no need to stop and measure how much the odontoid has prolapsed into the foramen magnum. When you can clearly see that the Chamberlain's line is violated. So that's why I don't get into so much in detail with the millimeters. Again, with the McGregor's line, see why the McGregor's line is important, because in this patient, the hard palate extending over to the inferior part of the occipital bone has been breached by the McGregor's line. But if we drew the Weckenham line, the posterior cleval line in this patient, we would see that the odontoid has not prolapsed over the Weckenham's line. Then that would get us confusing. So we use all the tools we have in our hand. And when we combine the Chamberlain's line and the McRae's line, we can see on the right side of the screen that this patient, this young patient, has the odontoid both prolapsing over the Chamberlain's line and over the McRae's line as well. Weckenham's line, the posterior cleavage line should be usually aligned with the odontoid. The odontoid should not pass over the Wackenham line, but you can see on the right side that the odontoid has prolapsed over the Wackenham line. And when we put the Wackenham line next to the McRae's line, then we can measure the Bogart's angle. See that you see the Bogart's angle has really increased over our limit. And when you look on the left side of the screen, you can see the anatomically correct patient with the Bogart's angle intact. So after finishing on how we should diagnose these patients, comes another major handicap, the classification. Classification, again, became so confusing because when you have so many different diagnostic tools, the classification becomes complex as well. But that's not the main reason. The main reason is these patients have a lot of clinical variability, meaning each patient is a clinical entity on their own. So it's difficult to categorize these patients according to their symptoms, according to their clinical finding, when they have so much variance. And also these patients show different symptoms in different parts of the world. So regional influences also affect them. I mean, Professor Goel's patients from the Indian subcontinent have different findings from the sub-Saharan continent or from the European side. But we do need a uniform classification in order to communicate, in order to categorize and follow up on these patients. And it also would help us to have a uniform decision on the surgical indication, the type of surgery, and the additional interventions, the additional treatments that these patients might need. And in order to do that very clearly, we need to understand the underlying etiology. The reason why I discussed the etiology part of basilar invagination in the beginning part of my presentation is because of this, because when we understand why this patient has a basilar invagination, when we can enlighten the underlying reason for it, then we would be better able to treat this patient, because we would be better able to decide if this patient needs surgery and what kind of surgery that this patient may need. So in 1997, Goel tried to classify these patients, and at first, he just used whether these patients had a Chiari or not. So he said patients that did not have a Chiari were group B, group 1, and that these patients were more prone to have an instability, to have an atlantoaxial dislocation and needing fusion surgery. But in group 2, he said these patients all had Chiari, and it was more of a cause of a decreased posterior fossa volume, causing an overcrowding in the posterior fossa. So these patients would have been better treated with just decompression, sometimes combined with fusion or not. So this is from his paper. You can see the odontoid prolapsing into the foramen magnum very clearly. And this patient does not have Chiari, it does not have the cerebellar tonsil migrating toward the spinal canal. But in his second group of patients, these patients have odontoid prolapsing into the foramen magnum along with tonsillar herniation. But this was an oversimplification because these patients were not uniform within their cells. Patients with Chiari sometimes had instability, sometimes had stable findings, whereas patients that did not have Chiari sometimes had syringomelia and other findings as well. So in 2004, he changed or he improved on this classification and abandoned whether these patients had Chiari or not. He did not use it as a classification. Instead, he used the lines that we just mentioned. So in group A, again, he focused on instability, but he said that if the odontoid tip was above all the 3 lines, Chamberlain's line, McRae line, and the Wackenham's line, this was group A, and these patients were unstable. But in group B, he said the odontoid tip was only above the Chamberlain's line, but was below the McRae line and the Wackenham's line. So this is why it's important that you are very familiar with these lines. So you can go over these lines and try to familiarize yourself with them. And the best way to do that is just use random CT scans in patients and try to draw them. These are very simple lines. And once you do them in 3-4 patients, you will get a very rough idea and you will be familiar with them. So what kind of patients were these? See, this is a group A patients according to Goel's classification. This patient has an odontoid tip lying above all the 3 lines, the Weckenham line, the McRae's line, and the Chamberlain's line. So an odontoid tip lying above all 3 lines in 2004 classification was an unstable patient. And again, this is another patient of Goel where you can see the odontoid tip is lying over the Chamberlain's line, the blue line, but it has not surpassed the McRae's line, the yellow line, or the Weckenham line, the red line. And these patients had an anatomically aligned clevis with odontoid, and it was more of a stable patient that just required decompression according to Goel in 2004. And then Menezes group published a paper in 2008, which is very important too, because up until to this point, we either focused on if the patient had a Chiari or if the patient had a stable atlantoaxial joint. Menezes performed a dynamic MRI in his patients, and he tried to find whether these patients had a reducible or irreducible basilar invagination, which is a new definition into this pathology. So if the patient was able to be reduced in the MRI, then the junction is unstable. So these patients, he said, that required fusion. But if it was irreducible, then it was a stable junction. So these patients would definitely require decompression, and you may or may not employ fusion along with these patients. See, this is an image from his study where the patient has a flexion, and you can see the compression increasing majorly in the foramen magnum. And when the patient extended, there was a normal alignment. So this is a reducible patient. And this reducible patient means that this is an unstable patient requiring fusion as well. So afterwards, Goel now focused more on atlantoaxial instability. But again, his simplified classifications became more confusing in 2018, unfortunately, because he classified the patients into group A and group B, and then he came up with subtypes. So what are these? In group A, again, it's an unstable patient where requiring fusion surgery, or group B, it was a stable patient with just structural bone anomalies. And then he further went on to create 4 different types for each group. But why did these get confusing? Because he used terminology with his own definitions. Like he used terminology such as external syringomelia, which is not very common in the literature. We are all more familiar with internal syringomelia. By definition, syringomelia is internal. And then he combined these internal, external syringomelias with combined syringomelia. And then he went on further stating that some of these patients had cavitation. So again, he has a stable group A patient, group B patients, and an unstable group A patients with 4 different types. Why did these get so confusing? Because this is an image from his study. You can see the odontoid prolapsing and compressing in the foramen magnum. You can see the facet instability at the C1, C2 level. But with his new classification, this becomes very confusing because first you need to define the group, which is group A in this patient, and then you need to define the type. Why is it difficult? Because he used the term external syringomelia, which he states is the accumulation of CSF external to the spinal cord. So this is a very subjective approach. You can see the CSF accumulating in the spinal canal, but whether or not this is pathological or not, it's hard to diagnose. This patient also has external syringobulbia, where you can see the accumulation of CSF anteriorly to the pons. And this is, again, a very subjective approach. I mean, this could be normal, this could be pathological. But I would rather have these patients classified more simply, because the more complex classifications you get into them, the harder it is to deal with these patients and treat them or follow up on them. So in 2025, this year, WFNS came up with a more simplified version of Basilar Imagination, which is easier actually. And Atul Goel was also in this spine committee, and they termed Basilar Imagination as if there weren't enough different names for Basilar Imagination, a new title, and they named it as craniocervical kyphosis. And when these patients were aligned with etiology, when they were classified with their etiology, it was simply put two different groups, the primary group and the secondary group. And the primary group, as we all know in all pathology, is the congenital group. It's something that you are born with. It's a developmental anomaly. So all patients with developmental anomalies or pediatric diagnosed in very young stages of their life are primary patients, and the secondary patients are acquired, something you get later on. It could be due to rheumatoid arthritis, it could be due to Paget disease, osteogenesis imperfecta, parathyroidism, rickettsia, etc. And this is very simple. It's very easy, and I really support something more simply, because this does not need to get more confusing. Instead, it should be more simple. And the main handicap of this classification is just etiology based. It doesn't focus on treatment, or it doesn't focus on the findings of the patients. So in the same paper, and they classified these patients into two different types. And this was aiming towards whether or not these patients needed fusion surgery, or whether or not decompression was enough. And this is pretty good, because it's simple. Type 1 is patients that have atlantoaxial dislocation, which are unstable patients, and type 2 without atlantoaxial dislocations, which are stable patients. And in their paper, in the WFNS Spine Committee recommendation paper, the final key points, they stated that the basilar imagination may create clinical findings according to the compression of the spinal cord, according to the compression of the medulla, according to the instability of the C1, C2 facet joint. And X-ray, CT, MRI should all be used for the diagnosis. Treatment-oriented classification, the one they proposed, is very simple. Type 1, type 2 should be used, and this could help with the publications as well. And they stated that McRae's line, Chamberlain's line, and the Bozkurt angle is the most reliable method in the diagnosis. So to sum it up, basilar imagination usually comes with associated anomalies. We should be familiar with other anomalies that these patients have. I did not get into a lot of those details, because I just want you to focus, and then I want you to be comfortable in diagnosing these patients, because I, as a resident, felt very insufficient in finding these patients. Which patients should I refer to my mentor, to my professor, if there's a suspicion of basilar imagination? So become familiar with radiology. All neurosurgeons, I believe, should be very comfortable with reading MRI, making simple measurements. Most of the time, I do not rely on radiology reports, because the perspective I see as a neurosurgeon is different from the perspective as a radiologist sees. So you should be very familiar in trying to diagnose the major anomalies, the major lines, the major angles. Every patient has a different radiological presentation, which is why we have so many different lines. We have so many different angles. But those 4 lines and the Bozkurt angle that I mentioned is more than enough for you to define basilar imagination. Patients will continue to be different. This is why it's hard to actually classify them into a very simple category, but the WFNS has done a pretty good job at that. And then we should ask ourselves, if this patient has a basilar imagination, is it reducible or is it irreducible? Is it stable or is it unstable? You have a lot of tools in your hands. I mean, there is no one clinical entity, there's no one radiological evaluation that you can perform on the patient and you can say, okay, this patient is reducible, it's very unstable, and this patient needs fusion. This is an evaluation. Even more experienced surgeons have problems trying to decide on what kind of surgery this patient needs. So you sit down, you have a look, discuss this with your colleagues, and you use different methods at your hand. This is all for human health. I mean, you do this to improve the health of the patients. You don't do it because you have a lot of fun trying to draw lines over the screen. So use these methods, be familiar with them. Again, in conclusion, there is no symptom-based clinical classification yet, which I believe is necessary, but is very difficult because there's a wide range of clinical findings. McRae line, Chamberlain's line, McGregor line, and the Bozkurt angle. Take-home message, be familiar with them. Define the cause of the symptoms. Does this patient have symptom because of an instability? Does this patient have a symptom because of the spinal cord findings, because of syringomelia? Or does this patient have findings because of their brainstem compression? This will help you when you are trying to choose the type of treatment. So I would like to thank you all for coming at this early hour and keeping up with me.
Thank you, sir, for this excellent talk. We will take any questions that the participants have.
Sure, could you repeat that?
Hello, Dr. Ismail. Can you hear me? Hello,
Hello.
sir. Can you hear me?
Yes, I can hear you.
Yes, sir. I'm Dr. Kabir. It's a very good presentation and very useful presentation for us.
Thanks.
Just I have two simple questions. First one is that the second last slide you have shown that we can go for decompression versus fusion. So it could be 180-degree and 360-degree. So how can we fix this at 360-degree? Either we can, if we are going to decompress anteriorly, then we fix posteriorly. So is it possible in this situation for CV abnormality, we can fix 360-degree?
You are right. This slide may be confusing. I put that slide as not of a treatment modality, but the different approaches we have and why we are always discussing on what we should perform in these patients. There are publications on these patients, especially from China, where there's fusion performed anteriorly. And they have tried to fuse the odontoid body itself. They have tried to plate the C1, C2 anteriorly as well. So why 360 degrees? I mean, maybe these patients have an oversimply, wiring of the posterior parts, or, pedicle screws, transmass screws, and anterior approaches. But this is not something, as I put there, to have a treatment modality. It's to show that there are different methods and different applications for these patients. And when we are trying to find the right treatment method, we should focus on whether if it's reducible, if it's stable or not.
Okay, so I deduce from it that 360 means that you can go anteriorly and decompress. That is rare. Now we can reduce all things via posteriorly, as I gained
Yes,
from your
definitely.
presentation, and then fix posteriorly. So that means this is the meaning of the slide that I learned.
Yes.
And second question is about that you have said according to Dr. Atul Ghosh 2018 and 8 classification, these are divided into A and B.
Yes.
and A is irreducible, so we have to fix that. So sometimes in few patients, that is also Dr. Atul Guru series, that there is syringomyelia associated with type A. That could be internal syringomyelia. So in this situation, either we fix along with decompression or just we fix the C1, C2 as we usually do in group A.
Uh,
So
what
this is
was
my
the
question.
first approach? What do you do in these patients?
Can you hear me, sir?
Yes, I can hear you. I just didn't understand the type of approaches you asked me.
Unmute, sir.
You have a group A patient with internal syringomelia.
Yes. So question is that with the group A patient after fusion, either we go decompression or just we fuse it.
Oh, Goel says that if you just stabilize these patients, the other findings would be improving on their own. He says that syringomelia is caused by the instability of the patient. So he says when you fuse these patients, the syringomelia with time will get better. So according to Goel, you don't need to perform any additional decompression, just fusion is enough. But according to my practice and some other doctors' practice, if the patient requires a decompression, I perform a decompression as well. If the patient has a very wide syringomelia causing symptoms, then I try to treat the syringomelia as well. But Goal just focuses majorly on the fusion. And he says he has some series of patients where he did not treat the syringomelia. He did not treat the compression. He just fused the patient. He created a stable patient. And in the end, the patient actually did improve in his series.
One last question from our side is that if, as you explain all of the lines, sometimes the measurements are suboptimal for all the lines, even for the Bogart angle. So in this type of patients, do we need dynamic MRIs, or do we need the patients to be symptomatic to go for any surgical intervention, either decompression or fusion?
Yes, definitely. I mean, these lines are performed on, radiological evaluations and radiological parameters, but we perform surgeries not on radiology, but on patients. So clinical findings always override the radiological evaluation. So when we have a patient that is symptomatic, and when we perform these lines, and these lines sometimes don't give us anything. I mean, they always seem normal or sometimes confusing. Then you can take the clinical findings of these patients and try to correlate it with dynamic MRI. If you can perform flexion extension MRI, it's not always possible in all the places. Then MRI would be very useful because it would show us if there is a compression of any kind of neural structures. Then we can say, yes, this patient has findings due to neural structure compression. But if the patient only has a suboccipital headache and no other neurological abnormality, then an MRI would not give us a lot of different findings. And performing surgery, on a clinically stable patient just because they have a suboccipital headache may be over-treatment. So always take the clinical findings and try to correlate it with MRI findings if there are any neurological abnormalities with the patient. And there are a couple of questions in the chat room which I'd like to answer as well. Krishna asked whether Bogart angle decides on craniocervical fixation. No, Bogart angle alone does not decide on craniocervical fixation, but it is very sensitive to basilar invagination. But it is not sensitive to whether this is a stable or an unstable patient. Craniocervical fixation usually depends on the stability of the patient. If it's a very unstable patient, then we may go for fixation. But most of the time we have instability at the C1, C2 level. So not a lot of these patients require cranium and occipital plating. But if you do find that it is reducible majorly, and if the patient comes into a good alignment intraoperatively, you can add the cranial fixation. But cranial fixation really decreases the quality of life. So most of the time I perform C1, C2 posterior fixation, which is usually enough. When would you do craniocervical fixation? I think I answered that most of the time. If the patient has a stable finding and does not have a lot of C1, C2 instability, then we may go for posterior decompression alone. Do we have any other questions?
Thank you, Dr. Ismail. This was a very wonderful lecture, and I think you gave us a lot of information. Okay, sorry to, I'm Dr. Yusuf. I'm an assistant professor over here in Liaquat National Hospital, working with Professor Salman.
Oh, nice. Thank you so much.
Tell you again, this was a very wonderful presentation, and I think all of us had an excellent amount of information. So let's hope we can translate this into clinical practice as well. And thank you so much for your time.
Thank you again, and thank you, Professor Sharif. But I advise younger colleagues to use these lines frequently. I mean, sometimes, surgeons don't have a lot of time, and they try to, simplify methods. Surgeons like it when it's very simple, but this is not a very simple clinical entity. So just become more and more familiar with the lines and the angles, and I believe you won't have a difficult time in diagnosing these patients.
Thank you
again, and my best to you all.
We look forward to seeing you in more lectures, hopefully.
Hopefully, I would be delighted. I am honored to be alongside with my colleagues from different parts of the world. And I hope you all have a good day.
Thank you. Bye.
Once again.